زملائي الأعزاء. During my journey, when I was searching for my topic, an interesting sentence come in attracting my attention. It's all in your head. Really, it's representing the God creation of a master of a gland in our head, which is the pituitary gland, which has a vital role to control many functions in our body. And today we will talk about a very interesting pathology in the pituitary gland, which is the pituitary adenoma. Let's start with the anatomy of the pituitary gland. The pituitary projecting inferior to the hypothalamus and connecting via the infundibular stalk. It is residing in a saddle-like concavity in the basis sphenoid, known as the sella torsica. This is the sella torsica, and covered by a dural shelf, which is the diaphragmatic sella. And superiorly, there is the suprasellar cistern, which containing the optic chiasm. Here, laterally on each side, there is the cavernous sinus, which containing the internal carotid artery and the cranial nerves. Inferiorly, this is the sphenoid sinuses. And when there is a lesion in this area, we must have a system and a step-by-step analysis to reaching the differential diagnosis. First, to identify the pituitary gland and sella torsica and determining the epicenter of the lesion, whether it is in, above, below, or lateral to the sella, and analysis of the lesion in the imaging according to the signal intensity, cystic, solid, fluvoid, and any calcification. So we will reach the differential diagnosis more easily. And this is the coronal T1 weighted MRI showing the normal anatomy of the pituitary gland. And this section is very important to normal anatomical subluxation of the pituitary gland and the lesion detection, whether it is intracellular, supracellular, or infundibular stalk. This is the infundibular, this is the optic chiasm, and this is the infundibular stalk, the pituitary gland. On each side, there's a cavernous sinus with the internal carotid artery. And as you know, that the pituitary gland is composed of two lobes, the anterior adenohypophysis and the posterior neurohypophysis. The anterior pituitary gland is composed of three parts, which are the pars distalis, pars intermedia, and pars tuberalis. And all these three parts will regulate the function and secretory cells in our gonads, which are the gonads, thyroid, adrenal, and other glands, and controlled by the hypothalamus. And the anterior pituitary gland will secreting hormones, which are the growth hormone, thyroid stimulating hormone, adrenocorticotropic hormone, FSH, LH, and prolactin. While the posterior pituitary gland didn't analysis or didn't synthesis the hormones, it just released the oxytocin and vasopressin, which are synthesized in the hypothalamus. And the pituitary gland will adapt according to the age of the patient and changes. It will adapt in size. So in the children, it will be less than 6 millimeter and has a flat or slightly concave surface, or the diaphragmatic sella will be flat or slightly concave. This is the normal. And in the adult, it has a median maximum height of 8 millimeter plus minus 1 millimeter. But in the puberty and pregnancy, postpartum, and lactating period, it will increasing in size. And strikingly, postpartum and lactating, it will reach 14 to 15 millimeter even. And also in the perimenopausal period, there is increase in size, but after the 50 years old, it will gradually decrease in size also. And when there is a mass, the fundamental question was, can I find the pituitary gland separately from the mass or not? So if we can, so the gland is the mass, and think about the macroadenoma, which is the most common. And if the mass is clearly separated from the gland, so it is extrapituitary, and think about other pathologies like the meningioma, craniopharyngioma, and other differential. There is a 30 different lesion around the pituitary gland or in the pituitary gland, and 70 or 80 of them are cellular or juxtacellular. due to one of the big five. The big five are the macroadenoma, meningioma, aneurysm, craniopharyngioma, and astrocytoma. And we need a clinical keys to reach the diagnosis, which are the patient age. And regarding the age of the patient, in the adult patient, we must think about the macroadenoma, meningioma, aneurysm. But in a child boy, when the lesion looks like adenoma, almost it is never neoplasm. And we must think first about the physiological hyperplasia or secondary end organ failure like the hypothyroidism. Other child lesions in the optic chiasm and hypothalamic region are the pilocytic astrocytoma and the craniopharyngioma. Regarding the gender, the second key, in the female, we have a plumpy pituitary gland during the menstruation and postpartum, and this is physiological. Keep this in your mind. And in the imaging, we talk about it and mention the analysis of the signal intensity, calcification, solid or cystic, and etc. So what is the pituitary adenoma definition? It is defined as a benign, slowly growing tumor from the ectodermal endothelial origin of the adenohypophysis. And when I ask myself, what is the adenoma? How is the pathophysiology of it? It is due to the multipotent stem cell, which is found in the pituitary gland, the oncogene activator, and loss of the tumor inhibition factors, uncoordinated proliferation in the stem cell, leading to the tumor genesis and adenoma. And there is many steps and factors leading to that. And I will settle for such, I don't dive in more details. And they are not encapsulated. They will displace the adjacent tissue. They are two categories of the adenoma, which are the microadenoma, less than 1 centimeter, and mostly it is endocrinologically active, and macroadenoma, which is more than 1 centimeter, and it is often non-functional but mass effect. Most adenoma within the cell and reported cases showing sphenoid nasopharynx, third ventricle, supracellular cistern, and ectopic cases of pituitary adenoma. Adenoma from the adenohypophysis, like prolactinoma and growth hormone adenoma, are lying laterally, while the TSH and ACTH tumor are in the midline. Regarding the size and number, they are varying from microadenoma to giant adenoma, which is more than 5 centimeter. They are usually solitary. Multiple synchronous are unusual, and double and triple adenomas are found in 1% of the autopsies. Pituitary adenoma accounting for 10% of all intracranial neoplasm, it is 30 to 50% of the pituitary region masses. The macroadenoma are approximately twice than the microadenoma, and the microadenoma are more common during the autopsies. The peak age of a presentation of the adenoma in the 4th to the 7th decade, 2% only in the children, and mostly in the adolescent females, rarely in the male. 5% of the adenomas are familial. All other are sporadic adenoma. The adenoma, when there is familial adenomas, it is presented in 4 categories or 4 inherited syndromes, which are the main type 1, Carney complex, Macoun-Albright, and familial isolated pituitary adenoma. Regarding the main type 1, it is autosomal dominant and plurihormonal adenoma secreting the prolactin and the growth hormone. Usually it is large and invasive. And the Carney complex, it is presenting with the spotty skin pigmentation, myxoma, growth hormone adenoma, schwannoma, adrenal ACTH independent Cushing syndrome. Macoun-Albright, it is a triad of the gonadotropin independent sexual precocity, cafe au lait, fibrous dysplasia, and nodular pituitary hyperplasia. While the familial isolated pituitary adenoma syndrome, only pituitary tumors, they are presenting with 40% prolactinoma and presenting earlier in age than the sporadic. Larger and cavernous sinus are more common for invasion. Main type 1, it is associated with parathyroid hyperplasia, pancreatic tumor, and pituitary adenoma. The clinical presentation of the adenoma, most of the adenoma become either asymptomatic incidentuloma, it is in 20% of the cases, hormonal imbalance, which is most commonly with microadenoma, and mass effect, which is most commonly with macroadenoma. And classically, it will affecting the optic chiasm. Rarely, it is presenting with catastrophic syndrome, which is the pituitary apoplexy. Regarding the hormonal imbalance, over half of all adenoma are secretory. Some only diagnose when there is a mass effect. And most of the secretion are prolactin, which is 50%. Other hormones are less in ratio. The growth hormone in 10%, adrenocorticotropic 6%, thyrotropin 1%, and other are mixed. Non-secretory are 35%. The female with the prolactinoma presenting with amenorrhea, galactorrhea syndrome, hyperprolactinemia due to the stall compression, it is due to the interference with the dopamine inhibition of the prolactin secretion. Normally, the prolactin is 100 to 200 nanogram per ml, whereas the male with adenoma presenting with a hypogonadism and impotence, the growth hormone adenoma representing as acromegaly in the adult, gigantism in the children, ACTH with a Cushing disease, Nelson syndrome, TSH, hyperthyroidism. The mass effect, most of the cases of the macroadenoma, as we mentioned, it is affecting the optic chiasm and leading to the visual disturbance and headache, while the diabetes insipidus is rarely associated. The invasion into the cavernous sinus is a poor prognostic sign, and the dural thickening, it indicates the aggressive lesion. Occasionally, it will compressing the cranial nerve like the oculomotor and less frequently the abducent nerve. Uncommonly, large tumor may result in hydrocephalus by compressing the midbrain or distorting the third ventricle, orbital or sinonasal symptoms. It will encase the carotid artery when it is large but not narrowing it, in contrast to the meningioma and metastasis that will leading to the narrowing of the carotid artery. It can bleed after the medical treatment, and which is different from the apoplexy. Apoplexy syndrome is a severe headache and endocrine dysfunction that is caused by hemorrhage into otherwise normal pituitary glands. The microadenoma is small, so we will depend on indirect signals and signs to see and diagnose the microadenoma, like the depression of the floor of the cilia, expansion of one side of the gland, subtle upward gland convexity, and contralateral bulge of the infundibula. Regarding the imaging, the CT is very difficult to see the microadenoma and it is radiologist dependent, but the MRI is the gold standard and the investigation of choice for pituitary microadenoma, about 10 to 30% only seen with contrast. In the T1, the pituitary gland will be seen as isointense to the normal pituitary gland, and there is a three-way to see the microadenoma. First, the spin echo. T1 pre and post contrast, the 3 millimeter thin slices with interval and fat saturation to depress other signal from the clivus and surrounding area. The dynamic sequence by a rapid series with a time interval about 10 to 15 second post contrast using a thin slices, coronal contrast enhanced, and multiple pituitary location and time, which demonstrated a rounded region of delay enhancement compared to the rest of the gland, which will enhance. The delay imaging are variable. It is either hypointense in most of the cases in comparison to the pituitary gland, which is normally enhanced, isointense or hyperintense, and retained contrast. New techniques are used, which are the spoiled gradient recall using 1 millimeter thin slice. It is excellent for soft tissue contrast, but the disadvantage, it has a low signal to the noise ratio comparing to the spin echo. In the T2, variable appearance, but often a little hyperintense adenoma. There is other new MR sequence regarding the Siemens, which is the FreeZet, Star Vibe, and these will providing a high resolution, temporal and spatial resolution, a 3 dynamic study. using a 3 Tesla magnetome Skyra scan. This is a new Skyra scan, a high resolution volumetric and multi-phase dynamic images for the pituitary gland. Now, this is multiple sections of the pituitary gland. This is coronal, pre and post contrast, and sagittal pre and post contrast. As you see here, there is a bulge on the left side and a convexity of the diaphragmatic cilia. Post contrast, we will see a rounded lesion of hypointense surrounded by a hyperintense normal tissue of the pituitary gland. This representing the microadenoma with a delay enhancement. And this is the sagittal section. As you see here, this is the bulge, and this is the post contrast showing the delay enhancement, and this is in the T2. And this is the new technique of the star vibe MRI dynamic scan for the pituitary gland. As you see here, this is the microadenoma, and this is time to peak showing the pituitary microadenoma. This is a delay enhancement. This is the enhancement normally. And the use of the Ciprinha enable the visualization of the microadenoma in 3 planes. This is the microadenoma, and this is the graph of the normal pharmacokinetics of the adenoma, and this is the normal pituitary gland enhancement. As you see here, there is a gap for the enhancement of the microadenoma as it is delayed. When there is a suspicion of microadenoma, but the MRI is normal, how to reach the solution for this dilemma? We use the digital subtraction angiography, the enlarge, which is showing enlarged meningiohypophyseal trunk with a prolonged blush in the tumor, inferior petrosal and cavernous sinus sampling. So we will reserve the angiography for 2 situations, which are the confirm the presence of the microadenoma rather than non-pituitary sources, especially in the case of the Cushing disease. As there are many sources of extrapituitary ACTH, some lung cancer will secreting the ACTH extrapituitarily. And the other situation to lateralize the microadenoma and aid the surgical exploration. The macroadenoma are most common supracellular mass, and the classical appearance of it is the snowman. It is responsible for the majority of the transsphenoidal hypophysectomies. It will causing ballooning of the gland and enlarging of the cilia, compression and indentation on the optic chiasm, intracranial displacement and encasement of the carotid artery, but not narrowing it. Upward displacement of the third ventricle, obstruction of the foramen of Monro, and inferior extension to the sphenoid and the clivus in case of large tumors. This is the sagittal, the coronal section showing the pituitary gland with a snowman appearance. This is a macroadenoma and the snowman appearance of it, which is the classical appearance, and how it compressed the optic chiasm here. This is a sagittal section showing a macroadenoma with a fluid level, which representing a hemorrhage. Mostly it occurs in the apoplexy rather than macroadenoma. Imaging of the macroadenoma by the CT, bone window will showing enlargement and remodeling of the cilia and maybe the clivus. Giant adenoma will showing a skull base invasion. It is iso-intense to the gray matter, but cystic changes occurring in 15 to 20%, hemorrhage in 10%, calcification is rarely, it is occurring in 2%. Moderate heterogeneous enhancement on the contrast. MRI is the preferred method. Coronal pre and post contrast is the gold standard. Regarding the T1, it is iso-intense to the gray matter, and the larger lesion will appear as heterogeneous as there is a cystic changes, necrosis, and hemorrhage. And the bright spot in 20% of the cases, it will be absent and displaced superiorly in 80%. After the contrast, the solid component will demonstrating moderate, a bright enhancement, and subtle dural thickening in 5 to 10%. In the T2, typically it is iso-intense to the gray matter, larger lesion often we said and mentioned it is heterogeneous and vary in signal according to the changes. And the gradient echo and the susceptibility weighted images are more sensitive for detection of the hemorrhage. Regarding the optic chiasm compression, I will explain it on the picture. When there is a lesion compressing the chiasm, which carry the nasal retinal fibers, it will leading to the bilateral hemianopia. As you see here, when there is a compression on the chiasm, there will be a bilateral hemianopia. While the perichiasmatic lesion, it will leading to the ipsilateral nasal hemianopia, as you see here, number 3. But the irregular enlargement of the any lesion, and when there is affection of the optic nerve, there will be a complete blindness of the ipsilateral side. After the chiasm on the tract, there will be a decussation, and when the lesion compressing the tract, it will leading to the contralateral homonymous hemianopia. Inferiorly, when it's affecting the optic radiation, it will leading to the contralateral quadrantenopia, and on the occipital lobe, it will leading to the homonymous hemianopia. This is coronal section showing the pre and post contrast bulging on the left side of the pituitary gland and the right-sided deviation of the pituitary stalk. This is the post contrast showing the moderate enhancement of the macroadenoma surrounded by the normally enhanced pituitary gland. And this is the sagittal section, pre and post contrast. Here is another case of the macroadenoma, but it compress the optic chiasm mostly on the right side in this coronal and the sagittal section, and this is the pre and post contrast. Regarding the cavernous sinus invasion, most of the prolactin secreting tumor, it will invade the cavernous sinuses, and it will leading to typically the prolactin level will increase significantly after invading the cavernous. And as you see here, this is a case of the macroadenoma encasing the left internal carotid artery. And there is a grade of invasion that we determine it by drawing 3 lines, one medially, one laterally on the internal carotid artery, and one in the midline. And the grades are when the lesion didn't cross the first line, so it is 0. When it cross it, it is grade 1. Cross the midline, it will be grade 2. And when it cross the 3 lines, it will be grade 3. And when there is a complete encasement, it will be grade 4. As you see here in these pictures, this is grade 0. It does not cross the first line, and then gradually it will enlarge until the complete encasement of the internal carotid artery in grade 4. This is a case of a 40-year-old male with a coarse facies, and this is the skull X-ray of him showing the enlargement of the cilium. This is the investigation showing the growth hormone, which is increased, and all other hormones are decreased. This is the MRI pre and post contrast showing the macroadenoma here. And this is the axial section. As you see here, the rim enhancement with necrotic area in the center. The provisional diagnosis was pituitary macroadenoma with apoplexy leading to the pan, hypopituitarism, hypogonadotropic, hypogonadism, secondary adrenal insufficiency, and secondary hypothyroidism, diabetes, and cataract. This is a case of giant lobulated outline heterogeneous enhancement of the macroadenoma, which representing giant invasive prolactinoma in a 46-year-old patient with expansion, with expansion and giant adenoma, which was a prolactinoma. The test was showing just a central hypogonadism with IGF-1, which was low. This is a macroadenoma showing a cystic lesion which follow the CSF signal intensity as you see here. It is hypointense and in the T2 hyperintense. This is a cystic pituitary macroadenoma. And this is an interesting case of a 39 years old male referred for evaluation of hypercortisolemia, diagnosed as ACTH-dependent cyclical Cushing syndrome and underwent transsphenoidal surgery. And the surprise was the pituitary gland was completely normal, but the sphenoid sinus was diffusely stained with ACTH due to the presence of an ectopic adenoma. As you see here, this is the ectopic adenoma. Regarding the PET-CT, macroadenoma are hypermetabolic, both fluorodeoxyglucose and the choline tracer. As you see here, this is the macroadenoma. It is a slowly growing tumor over years, and the malignant transformation of the adenoma are rare. The treatment individualized accordingly: surgical treatment, transsphenoidal, and the craniotomy in case of large tumor, medical therapy for the microadenoma, stereotactic radiosurgery, and conventional radiation therapy for decreasing the size of the tumor. Regarding the differential diagnosis in the pituitary gland, mostly we will think about the adenoma, radic cleft cyst, and craniopharyngioma, and not forgetting the top hill appearance of the pituitary gland according to the age of the person in the adolescent period, as it is hyperplasia. This is a case of hyperintense lesion in the T1 and not enhancing on the T2 and not enhancing lesion and hypointense in the T2. And this is the craniopharyngioma. Due to the presence of the calcification, it will appear as hyperintense in the T1. Regarding the pituitary stalk, we think about the radic cleft cyst, craniopharyngioma, germinoma, eosinophilic granuloma, and metastasis. And this is a iso-intense lesion in the T1. In the T2, it is hyperintense after the gadolinium, just rim enhancement, and it is not enhancement. And this is the radic cleft cyst. When there is a non-enhancing extra axial mass, think about three possibilities. It is either a rapid arterial flow and it is large blood vessel, or there is no cellular tissue and it is a cyst, or there is no blood supply infarcted mass. Regarding the optic chiasm, think about the glioma and demyelination, meninges, meningioma, and inflammation. And here, as you see here, this is a lesion with a dural tail enhancement in case of meningioma. And the carotid artery, think about the aneurysm, ectasia, and anomalies. And don't forget the normal variant, which is the kissing internal carotid artery, which is very important in case of the transsphenoidal hypophysectomy. Duplication of the pituitary gland here. And the ectopic bright spot of the posterior pituitary gland. Take-home messages. Knowledge of the cella and supracellular region anatomy is essential for the diagnosis. MRI is the investigation of choice. The most common cellular lesions are adenoma. The CT is important in evaluation of the calcification and bone involvement. Patient with a vision-threatening pituitary adenoma should undergo early neurological management to save his vision. And before the pituitary surgery, adrenal insufficiency should be evaluated and treated to prevent the adverse outcome. This is my sources, and thank you.
شكرا جزيلا دكتورة